Am I audible?
Yes, ma'am.
Okay, thank you. Good evening, everyone. I welcome you all to the second day of the first Paras Cancer Conclave. It was a very encouraging and exciting day as yesterday we had almost about 800 delegates joining in 4 halls. We had dedicated sessions, live workshops, interactions with primary care physicians, a session on breast oncology. So today is the second day and we begin with our gynae oncology session in this hall. So without wasting any time, I would like to invite the chairpersons for the first session, Dr. S.K. Srivastava, a teacher, a mentor, and I am privileged to have worked with him as well. He is the ex-head of Tata Memorial Hospital Radiation Oncology, Mumbai, and currently the Director Radiation Oncology at Apollo Hospitals,
2034.
2021.
Dr. Arun Kumar Rathi, who is also a teacher and guide to many of the students who would be listening this conference today. And he's currently the director, professor, and head of radiotherapy at Maulana Azad Medical College and associated Lok Nayak Hospitals, Delhi. And we have with us Dr. Amita Maheshwari, who is the professor and head division of Gynae Oncology, Tata Memorial Hospital, Mumbai. I welcome all of you. A very good evening to all of you, sir, Dr. Srivastava, Dr. Rathi, and Amita ma'am. So I would now request you to please proceed. And as we have already shared that the chairpersons would be inviting the speakers and the moderator would be inviting the panelists. Please ensure that the speakers stick to time because we have an inaugural today which starts at 7. And we all have to complete the session by 7, this particular session. So over to you, sir.
Thank you, Aditi. It was really very nice. It's a wonderful program. And I've got the other chairpersons with me. Arun Rathi, I think Dr. Rathi, you can initiate and you can start.
सर आप शुरू करो सर. शुरू करो सर.
कर दो.
आप करो सर. आप करो. आप करो सर. आप करो.
I can see the Amita also. Amita, आप mute करो. Mute हैं आप.
Sorry. So I said, आप दोनों लखनवी नजाकत में हैं. Let me start. So very warm welcome to Gynec Oncology session. And in this, we have first talk by Dr. Jaya Ghosh. She's a professor of medical oncology at Tata Memorial Center, Mumbai. And she will be covering a very, very important and happening topic in the field of endometrial cancer. That's molecular classification of endometrial cancers. And she will be taking us through the future of this molecular classification as far as management of endometrial cancer is concerned. So over to you, Jaya. Jaya, are you able to get connected?
Yeah, I think she has come.
Good morning. Yeah. Good morning. Yes.
Ma'am, please start your screen sharing.
Thank you all. I just switched off my video because of yes. So I just thank you, Aditi, and thank
Ma'am, we
you
cannot see your
organizers
screen.
for giving me this opportunity. So I'll just share my screen. Can you?
Yes, ma'am, please share your screen.
So it is showing you.
Ma'am, your network is not strong.
Garima, if there is an issue, we can share Dr. Jaya's slides from our end.
Ma'am, this video so that you know the.
Garima, if there is an issue at Dr. Jaya's end, then sir, can we have the second talk first and subsequently we can have Dr. Jaya's talk?
Yeah, maybe we can start with Dr. Supriya, na, second talk, and then come back, and by the time it can be sorted out.
Right, sir.
Aditi, will you activate my screen share, please?
Garima, please give the screen sharing
Dr. Supriya Chopra. She is a professor and convener of Gynec Oncology DMG. She's a professor of radiation oncology at Tata Memorial Center, and she will be giving an overview of current advances in radiation techniques for cervical cancer, hope or hype. So I hope you are able to tell us clearly hope or hype.
Yeah, Aditi, that was a very interesting title. So I hope I'll be able to do some justice. So I think the technology, advances in technology. So typically for cervix cancer, we have always, maintained that the treatments have to be very simple because it's a disease of low middle income countries where all these technologies may not be available. But I think at the same time, it's also important to see the scientific advances in perspective of their benefit and risk. So in the next 15 minutes, I'll be talking about the role of image-guided IMRT and brachytherapy for cervical cancer in primary treatment, setting of retreatments, and a bit about stereotactic radiation and spatially fractionated radiotherapy. And I think it's always good to go back to the modality that led to biggest change in outcomes of cervical cancer after radiation for locally advanced, and that was integration of platinum. And since year 2000, when all these randomized trials and subsequent meta-analysis came, it was very clear that you have 8 to 10% improvement in outcomes, progression-free or disease-free survival, but at a cost of increased gastrointestinal and hematological toxicity. And we began to see a lot of neutropenias and GI toxicities while administering this treatment during the course of radiotherapy. And when platinum was also integrated in patients receiving conventional radiation extended field, one could see that acute toxicity would be seen in at least 3/4 of the patients, grade 3 or 4. But a significant proportion of patients would also have late toxicity in this particular cohort, making these treatments very difficult to implement. If I remember way back in 2005, 2006, when we were using more conventional techniques for EFRT. The other major change that has happened in cervical cancer radiotherapy is the integration of one, advanced imaging, and second, advanced applicators. And in the last couple of years, mostly by the initiative of the European groups, there has been a very concrete evidence which has come out that there is an increase in local control when you integrate advanced image-based brachytherapy, and the local control could be gained to the quantum of 10 to 15%, depending on how small or how big the tumor is. But again, most of these data have been single arm, large registration studies. But very nicely, if you look into the data, it is very clearly evident that patients who typically had poor response to external radiation, which means that they have a large target volume at the time of brachytherapy, you could estimate that these advanced techniques would benefit them the most, with at least a 10% increase in local control. And from the data that is soon to be published, but also previously published from our institution, one can see that the 3-year outcomes for even stage 3B were upwards of 85%. So there is always an argument that these are highly selected patients going into international clinical trials, fittest of patients, whatever you are seeing, whether that's real or not. So we recently completed, because there is no data currently available from randomized studies, so we completed a meta-analysis of around 5,200 patients, and this is ready for submission now and also presented in Astro last year. We compared all series of 2D brachy versus 3D brachy, including all the patients also recruited into the EMBRACE study. And there is a clear impact of 7% in disease-free survival while integrating advanced brachytherapy. Obviously, these are not prospective studies barring a few, but this is the best evidence that we have towards to date for integration of advanced techniques for image-guided brachytherapy. What is also becoming obvious with these advancements is that there is a changing pattern of relapse. Previously, we thought that local control is one where we need to gain, but now that local control is in place, you can see from these figures that a large proportion of patients would have regional, paraiotic, or systemic relapse. We will talk about systemic relapse in a while, but there is evolving data in world literature which suggests that probably nodal dose escalation, because typically we've given around 50 gray or including brachy boost, 52 gray to the nodal regions. But if you're able to dose escalate nodal dose, there is an increased probability of local control. And here you can see that if you move from 50 to 60 gray, there is an expectation of increased nodal control, more so in smaller volume nodes as compared to larger volume nodes. But when you try to do these using conventional techniques, there is now some published data to show that this comes at a cost of increased gastrointestinal toxicity. And you can see using conventional techniques, if the irradiated volume is large or the prescription dose is large, the patient can expect to have higher toxicity. So this is also evident also from post-operative cohorts from endometrial cancer, not directly to be extrapolated to locally advanced, but to post-op cervical cancer, that most of the conventional techniques do have long-term sequelae. And integration of new techniques could probably reduce a significant amount of morbidity and possibly improve local control and pelvic nodal control. So the questions that we have to ask while integrating advances in technology is that, can we maximize pelvic control? Can we reduce morbidity, both in definitive and adjuvant setting? And can we very smartly use advanced techniques to retreat nodal and distant relapses? Because we know that systemic agents are not very successful as far as cervix cancer is concerned. So the first evidence for use of advanced technology comes from All India Institute of Medical Sciences, a small randomized trial, but with very meaningful information. And here in the first time, you could see that one could see that use of IMRT would lead to almost half the rates of late toxicity. So this particular advanced techniques that I've been talking about are also now systematically being tested in a multicentric international study, Embrace2, where we are also participating from Tata Memorial Center. Around 1,500 patients will be recruited. So the basic aim of these studies is to use advanced image guidance for external radiation, also for brachytherapy, reduce the overall treatment time, improve compliance to chemo, and take the prescription dose to as high as 90 to 95 gray while maintaining normal tissue doses, much less than what we used to have using conventional techniques. So the idea is to improve control and reduce morbidity. So here you can see in this slide that this particular protocol aims to increase prescription doses for cervix cancer, 90 to 95 gray, and organ at risk doses reduced by 10 gray. So this is not an easy aim to achieve when you're doing conventional radiation, also conventional intracavitary brachytherapy, and at least 30 to 40% patients would need advanced brachy to reach this particular type of aim. So this is an example of how this treatment is made possible. So you can see here that a patient with locally advanced cervix cancer is being treated with advanced IMRT and image-guided brachy using certain principles of radiation which allow minimal dose to be spilled outside. And you can see here that we try to maintain conformity index of 0.99 to 1.06 while treating external radiation, but then also integrate advanced brachytherapy techniques in a significant proportion of patients. And you can see how from 2017 to 2020, we have come down in the irradiated volumes. This blue line represents the cohort that is recruited from Tata Memorial Center. And please keep in mind the toxicity that I mentioned at the beginning of this presentation. And when you see now into the Tata cohort, longitudinal follow-up of the patients, there are hardly patients with grade 3 toxicity, whereas previously we've had 60 to 70% 60 to 70% patients with toxicity, especially when they have extended field radiation. So right now there are 1,000 patients recruited in the world. And I think within 3 to 4 years, we will have some data coming out of these kind of advanced treatments. So in the last decade, we have moved from, though these are not very comparable cohorts, so we are able to deliver around 96 gray to HRCTV with a range of 86 to 100 gray, while maintaining rectum and bladder doses almost in an acceptable range to lower morbidity. So all these transition has taken quite some effort, because when you have so many patients of cervix cancer to be treated, all these things take quite a bit of time. So we also try to integrate technology of machine learning to deliver at least the external component of treatment. And here you see how we have integrated machine learning based treatment planning for IMRT to obtain these very good plans for patients, especially who come with nodal positive disease in our center. And we are able to generate these machine generated plans in a very less time. So this is also a different way where technology can be integrated. And here, this is a comparative assessment of human versus machine-based plans. And with our expert planners, here in this case, Jamima Swamidas, who's been working on these protocols for quite some time, the machine plans were found to be slightly superior to human plans. So there is much to be gained by integration of technology, both in perspective of time as well as efficiency. The other evaluation of technology that happened in our institution was a phase 3 randomized trial of postoperative adjuvant 3D CRT. So this trial was presented at ASTRO in October 2020, and tonight it will be presented at Society of Gynec-Oncology in the plenary session. So in this trial, we randomized patients between 3D CRT and IMRT and linearly followed them for toxicity and quality of life endpoints. And in a time to event analysis, we were very clearly able to demonstrate at least a 20% difference in toxicity-free survival with integration of IMRT. And this was also seen in patient-reported outcomes, because a very small proportion of patients continued to report serious adverse effects up to even 5 years of follow-up. So extending now this technology to a very different cohort of patients, which are patients who present with relapse. In our country, recurrence after surgery is very common, because many patients get treated in peripheral centers and with surgery which is not using the oncological principles. So we integrated advanced imaging for these patients, because typically if you look into their outcomes, their 3-year disease-free survival is in the range of 60 to 65%. So all these patients in a prospective Department of Science and Technology supported study underwent 3 or 4 different types of imagings, which included MRI, diffusion weighted imaging, mesonidazole PET, and FLT PET. And we did quite a bit of integration of this imaging in understanding the target to be irradiated, and also for brachytherapy. Here you can see how images were studied for all these patients for areas of hypoxic area, proliferative area. And in all these patients, we implanted the composite volume that was at baseline. And this cohort of our patients, which this is now published in the Red Journal, is actually reporting one of the best outcomes in world literature for post-surgical recurrences. And you can see we have up to 7-year follow-up with local control of 84% and DFS of around 70%, and with very maintained quality of life, which is already published in this paper. Post-radiotherapy recurrences where technology can be used is another indication. And this slide shows the spectrum of recurrences which can happen after chemoradiation, either central, peripheral, and a very small proportion of patients are actually eligible for surgical exentration. And in our institution, we have traditionally been treating whenever it is possible with brachytherapy with combination of external radiation. But now we have outcomes that are published, where our institutional data you can see here is also quoted. And you can see that with integration of brachytherapy, one can expect at least 70 to 60% local control at 5 years, whereas if you give only palliative chemotherapy, these patients won't go beyond 12 months. This is an example of using advanced imaging for treatment. A patient with C endometrium treated with only brachytherapy in 2020 record with periurethral was not eligible for surgery, and we used a combination of external radiation and interstitial brachy for her treatment. Similarly, advanced technologies like stereotactic read-RT can be used in patients where brachytherapy is not feasible or surgery is not feasible. And this is a summary of various series, and you can see that the follow-up of these series is going up to 31 to 40 months, again suggesting that integration of radiation helps.
Supriya, sorry, I have to
Yes.
interrupt you. So I think you need to wind up
Yeah. So,
getting message from organizers.
Yeah. So to summarize, what I can say is that since last couple of years, there has been a lot of advancements in advanced technology where you can re-irradiate local relapses and distant metastasis, and outcomes of these patients can reach up to 20 months, not with known with systemic chemo or exenteration alone. And now a lot of trials are also going on in combination with immunotherapy. So I would like to conclude by saying that there is hope, not only hype, and definitely with integration and these advances, the outcomes will be better in future. Thank you very much.
Thank you, Supriya. It was very nice, and I must congratulate the entire team and DMG for such a nice work. And I was looking at there are some questions we can. So Aditi, I'm not sure whether you can have the question now or at the end.
So we can have the questions at the end.
Okay, right. So I think we will go for the first lecture now.
Right, sir.
Yeah, I think maybe Jaya, if she is ready here. Yes, I think she's sharing the. I think as Amita has already introduced Jaya, so she is going to speak on the molecular classification of endometrial cancer, expectation for the next decade. Jaya, she has started sharing the screen.
Yeah, ma'am. Can I share screen?
We will switch off our videos and audio.
So, can you see my screen?
No, Jaya,
No,
we
ma'am.
can't see your screen. We can't see your screen. And I think you need to be closer to your Wi-Fi connection because, yeah, now we can see your screen, Jaya.
Your voice is breaking. Screen, yeah, you can see the screen.
I think, Jaya, you need to be closer to the source of broadband. Your voice is not audible.
Uh, uh,
Aditi, can somebody check?
Sir, actually, we are
Yes.
sharing slides from our end. I think Dr. Jaya's network is not good, so she's not audible.
So some network can be
my
changed.
mobile. So maybe if somebody.
Ma'am, please log
Can
in
you
with mobile.
hear me now?
Any other
Because I've
mobile.
joined them from.
I think this will be an important lecture before the panel discussion.
So can you
If
hear me?
possible, we can.
So can you hear me now?
Yeah,
Yeah,
I
Jaya,
can.
we
We
can
can
hear
hear.
you.
Yeah,
It's
we can
much
hear.
better.
Yes,
Lovely.
ma'am. Yes.
Very nice.
Logged in from my mobile, so I'll just request the organizers to share the screen.
Yes, ma'am. Yes, ma'am. Please start.
Yeah, okay. Thank you and sorry for the technical glitches. And so just moving on quickly to the molecular classification of endometrial cancers in your expectations from the next decade. Next slide, please. So, we have for a long time have had just this type 1 and type 2 classification. And the need for molecular classification is because, of course, these type 1, type 2 classification have also served us and given us survival benefits. Next slide, please. So if you look that we have classically known that, endometrioid cancers do better than serous cancers. But at the same time, we've also had patients with 1B endometrioid cancer, what is looking like an endometrioid, good looking endometrioid cancer come back with metastasis in just a few years. And that is what kind of leads us to question ourselves that is there some good endometrioid cancers and some bad endometrioid cancers, or what is looking good on histopathology? Does it have a poor prognosis or metastasis? And that is what led us to the next, the TCGA classification. And the TCGA classification basically looks at 4 subtypes of these cancers. And these 4 subtypes are the polymutant, the MSI high, the copy number low, and the copy number high. So these 4 classifications are important. And why is it that, poly, which is like the hypermutated type, is the one which has best prognosis? And the reason being that once there are so many mutations, there are new antigens, and it is the body's immune mechanism which kind of takes care and of these mutant cells. So because of the new antigen presentation. Just go back to the previous slide, please. Yes, so basically, if you have these 3 subtypes, and so if you look at the P53 mutant or the copy number high, they are the ones which have P53 mutant. So what is, see, most of the serous cancers, what we classically know as the type 2 histology or the serous cancers would be P53 mutant. So what is important is like amongst the endometrioid cancers, we would have some which are polymutant, some of which are MSI high, and some which are copy number low or no specific mutation as some of the classifications would say. So although there is an overlap between the two, what we broadly was like a grade 3 endometrioid. So if it is a grade 3 endometrioid cancer but is P53 mutated, that is something which we would probably be at a higher risk and have a poorer prognosis than say a grade 3 endometrioid cancer which is MSI high. So both are grade 3 endometrioid cancers, but the prognosis would differ based on the mutation status and this classification profile. So next slide, please. So if you look, these are the polymutant is the one which is has the best prognosis, whereas the worst prognosis is of the P53 mutated at the copy number high serous like cancers. Next slide, please. So how do we, TCGA, we are not going to do a gene expression profiling for all these patients. So how do we clinically classify these subgroups? And the PROMISE group has very nicely come up with a simple method. So by routine immunohistochemistry, we can at least do the MMR testing and the P53, which can easily be done by immunohistochemistry. Checking for POL-E still requires NGS. However, at least we can get to know the MMR status and the P53 status by simple IHC, and that would give us a clue as to what subtype of the TCGA it is going to be. Next slide, please. So if you look at, there are some clinical surrogates, these are also older patients, low BMI who would be poly kind of muted, whereas the P53 abnormal is what would mostly be from the in the ones which are of the serous histology. They are the ones who would be, see, 80% of the non-endometrioid or the serous histology are P53 abnormal. So that is something that we need to know. But what is also important is that amongst what appears as clinically high risk, if you look at the ESMO clinically high risk, among what appears as clinically high risk, some of them may be polymutated and actually have a better prognosis as compared to the others. So it would help us delineate both from what within the clinically high risk group as to which are the ones which have a better prognosis as compared to those which have a worse prognosis. Next slide, please. Next slide, please. Can I go on to the next slide? Yeah, so I think if you look at both the ESCO-ESTRO consensus, which was there in 2016, and the present ESCO-ESTRO-ESP guidelines, definitions of low, intermediate, and high risk presently incorporate the molecular classification. So amongst this whole thing, what I would like you to remember is, like, if you look at the older classification, so if we had a stage 1, grade 3 endometrioid, that would become a high risk. But today, I know that if it is a stage 1, grade 3 endometrioid, but it is poly-type or no specific NSP type, then, or even if it is MSI high type, they are the ones which are probably have a better prognosis and have been moved up into the high intermediate group, or the intermediate group. Whereas if it is a 1B endometrial cancer, but it is of the serous type, or if it is 1B grade 3 endometrioid, but it is P53 mutant, that is what has moved into the present high risk classification. So today we see that this TCGA classification, or the molecular classification, is getting incorporated with the other clinical risk groups, and therefore it is going into the getting into and trying to impact the management for how we treat endometrial cancers. Next slide, please. Yeah, so important among this is that when we look at advanced stage 3 endometrial cancers and look at the POTEC3 data, of course, POTEC3 had incorporated all high risk early stage also. So, and if you look at the molecular implications in the POTEC3, we have seen that it is the P53 abnormal subtype, which is the one which has had the maximum benefit with chemotherapy. So if you look at P53 abnormal, that is P53 mutant versus not, that is the group which has had the added benefit of chemotherapy. Whereas if you look at the poly subtype, there is absolutely no difference between CTRT and RT alone. And similarly is the case with MMR, those who are MMR deficient or have no specific mutation. So there is some benefit in PFS and no benefit in OS, but that was not statistically significant. So what we conclude from the POTEC3 molecular classification and data from that is that the benefit of adjuvant chemotherapy is seen most in those who are P53 mutated, those who are stage 3, and those who are of the serous subtype. Next slide, please. Can I move on to the next slide, please? Yeah. So as I discussed, is that immune, if you look at why are these, poly mutant or the MSI high have a good response, as I said, because their DNA damage cannot be repaired and they have a lot of new antigen, and that is the reason for their better prognosis. And also when we have advanced cancers, one can use immunotherapy in this patients. Next slide, please. Next slide, please. Yeah, so, okay, so we just go back a previous slide. So we see that in those who are MSI high, presently we have the approval for use of pembrolizumab after they have received one line of therapy, basically when they've progressed after multiple lines, and we do not have any other standard treatment option, and that is the situation where one can use pembrolizumab for these patients. So these are mainly for MSI high cancers which have relapsed after multiple lines of therapy or do not have any further line of therapy available. Next slide, please. Yes, so then now there is this also amongst the serous subtype, we know that some of them have HER2 overexpression, and those that overexpress HER2, there's a small phase 2 study which has shown the benefit of addition of trastuzumab in patients with metastatic high-grade serous cancers overexpressing HER2. So, and there is a benefit in PFS of close to from 8 months to 12 months. Next slide, please.
Yeah, sorry to interrupt you. You can wind up in in 60 seconds.
Yeah, so that is my take-home message, that molecular classification has had an impact on adjuvant treatment, and especially in those we have able to escalate and therapy in those who have a worse prognosis as dictated by the molecular classification, and in future maybe we can de-escalate therapy in those who don't are like polymutant subtypes. And in metastatic there is a role of immunotherapy and there is a potential role of trastuzumab. Next, thank you.
Hello,
Hello, yes sir.
I'm audible.
Yes sir.
ये क्या हो गया?
Yeah, Arun, you can continue. Thank you, Jaya. It was really nice and presentation and quite new. And I think Aditi will move for the next, just to keep the time. Next is a panel discussion, and really it is going to be really very interesting. Dr. Abhishek Gulia will be the moderator. I'm sure Abhishek is there. He can come. And the panelists are the Umesh Mahanchetty, Dr. D.N. Sharma, Dr. Rupinder Sekho, Dr. Satinder Kaur, and Dr. Pariksha. So, Abhishek?
Yes, sir, I'm here, sir.
Yeah, please take care.
Yeah. At the outset, I'd like to thank the organizers and congratulate the organizers because they have arranged such a distinguished faculty. They have managed to arrange such a distinguished faculty for this session. And I'd like to invite the panelists. Can I share the slide? I'm not allowed to share
Yes,
my
sir.
slide.
Please, sir.
So we have 20 minutes for this panel discussion, and I really hope we can extract maximum knowledge from our distinguished faculty in this. I'd like to invite the panelists, Dr. D.N. Sharma. He's a professor in radiation oncology in AIMS and NCI, Jhajjar, Delhi. Dr. Umesh Mahanchetty, sir is professor in radiation oncology and currently a dean in TMH Visakhapatnam. Dr. Rupinder Sekho, ma'am, she is chief of gynae-oncology in Rajiv Gandhi Cancer Institute, Delhi. Dr. Satinder Kaur, she is a senior consultant gynae surgical oncology in Dharamshila Narayana Super Specialty Hospital, Delhi. And Dr. Pariksha Gupta is an assistant professor in gynae pathology in PGI, Chandigarh. So as far as just to set the ball rolling, I'm presenting a case of 66 years old female. She had a past history of carcinoma breast, which she received treatment for in May 2001 and presented to us in August 2020 with history of bleeding PV. She had a performance status of ECOG1. She was a diabetic. The ejection fraction was 60%. Chest X-ray was normal. The MRI pelvis revealed there was a uterine mass around 7 centimeters in size, which was expanding the endometrial cavity without any invasion in the myometrium. And the mass was extending up to the level of internal os. Hysteroscopic guided biopsy, endometrial biopsy was obtained, which showed it was a malignant tumor, high grade. Now, can Dr. Satinder please take this one? Will you do anything different in the pre-surgical evaluation of disease in such an early stage with high-risk histology presentation? I mean, do you really feel chest X-ray is good enough for metastatic workup?
Biopsy would have been sufficient. Secondly, we have an MRI pelvis, so I just did an upper abdomen evaluation for which...
We can't hear you, Satinder.
Hello?
You have to come a little closer to the mic, I think.
The volume is low, yeah.
Yeah. Is it okay now?
Yeah, audible.
Yeah. So, so the first thing is endometrial biopsy is sufficient. We don't need a hysteroscopy for a 7 centimeter mass in the uterine cavity, which we could see. I need an evaluation of the upper abdomen because only MRI pelvis has been done. So since it's a high-grade tumor, I would prefer a CT upper abdomen in this case, and chest X-ray is good enough, I think. Since there is no disease outside the uterus in MRI pelvis, there is no need of any going in for CT chest. Chest X-ray would be a good enough thing.
All right. So PET scan was done, which revealed that the disease was confined to uterus without any lymph nodes or any other distant metastasis. Dr. Rupinder ma'am, what should be the ideal extent of surgery? Is it different for these high-risk histology as compared to endometrial low-risk histology?
Yes, definitely. A high-risk histology would warrant a different kind of a surgery. And it would be so nice if we can actually define what is the high risk. Is it a serous cancer? Is it a clear cell? Are we looking at a carcinosarcoma? Or are we looking at something different? Having said that, even if it is a high-risk histology, a TAH BSO is quite enough for that. As far as the tumor is, as far as the local surgery is concerned, that is for the uterus. Except, of course, if we can determine that if it is beyond the internal os, then perhaps one would want to do a radical hysterectomy of type 2. Complete pelvic lymph node dissection should be done, and the para-aortic nodes should also be assessed. If the histology is serious, then we would have to also take mental biopsies as well as other biopsies, wherein the mental biopsy should be at least 5 centimeters in size. So this is the basic surgery that one would want to do. And of course, the peritoneal cytology as well. Even though the peritoneal cytology is no longer considered for prognosticating or for even the staging, but still we do it as part of the routine surgery.
All right, ma'am.
And one more thing, if we can determine that it is serious histology, an infracolic omentectomy would definitely be called for instead of a mental biopsy.
So our pathologist reported it just as a malignant tumor, high grade. He couldn't specify whether it was serious or not, but that is how it was. Dr. Satinder, is there a role of minimal invasive surgery in this high-risk endometrial cases?
So the initial lab trial was only for stage 1 and 2A endometrioid cancers, but now there have been sufficient evidence that if you can actually not disturb the uterine structure, you don't lead to spread of the disease, a minimally invasive surgery is good enough for, can be done for high risk endometrial cancers. But you have to take care that there is no rupture of the uterus, you don't need to morcellate the uterus, or we don't need to spread the disease in the abdomen. Basically, that has to be taken care of.
Okay. So I found out this this is a very landmark paper in which ESMO, ESGO, and ESTRO consensus combined guidelines were there, statements. In that, as far as these bodies are concerned, they gave that recommendation that minimally invasive surgery can be considered in, as rightly said by our esteemed panelist, in the management of high-risk endometrial cancer. And this is the paper on which it is based, that in women with high-grade endometrial cancers, fewer complications and similar survival outcomes were observed. Our case, she underwent type 1 hysterectomy with BSO, pelvic para-aortic lymph node dissection, and omentectomy with peritoneal biopsies. The post-op histopathology revealed endometrial serous carcinoma stage 1B. All lymph nodes were free, LVSI were negative, and the peritoneal washings did not show any malignant cells. As far as immunohistochemistry is concerned, it was CK reactive. P53 was diffusely and strongly immunoreactive. And final impression of endometrial serous carcinoma was made. This is has already been discussed very beautifully by Dr. Jaya. The Cancer Genome Atlas, TGCA as we call it, has advised that we should categorize these endometrial cancers, especially in nowadays in molecular groups, these 4 categories. Again, some surrogates can be used to classify these, has already been discussed, which is also recommendations of International Society of Gynae-Pathologists. So I'd like to ask Dr. Pariksha, apart from the conventional morphological features in the histopathology, like histological type, grade, LVSI, etc., what tests or molecular markers or IHC should be advised on the biopsy specimen for all endometrial carcinomas and high-risk histology in particular in today's scenario?
You are referring to the endometrial biopsy or the hysterectomy specimen per se, because in this case, the hysterectomy specimen P53 has already been done. Mm-hmm. So that could have actually been done on the biopsy also.
No, I'm asking about the post-op histopathology.
Post-op, okay. This is the hysterectomy. So since the P53 is already done and it is positive, so it would go into the P53 mutant type. But it has been observed that the POL-E category also, the POL-E type mutant category molecular classification, there also around 10 to 15% cases have P53 mutation. And we know, as JMM has already discussed, that this POL-E category is the category which will show a high-grade histopathological features, but has better outcomes in terms of progression-free survival. So I would definitely like to ask for a POL-E mutation here. Okay, since P53 is there, so POL-E mutation and MSI. MSI analysis, because if MMR mutations are there, so at least the patient can be offered the immunotherapy. That is the advantage. And if POLE is there, since limited studies are available whether adjuvant therapies are beneficial really in that group or not, as ma'am has already shown that there is a limited benefit in this category of patients, because these women tend to do better as compared to other molecular subtypes. So I would like to ask for MMR deficiency, which can be tested by immunohistochemistry, and I would like to ask for POL-E mutation, which needs a DNA-based method. Okay, that requires a PCR basically.
But doing a P53 by IHC, is it sufficient? Is it good enough?
That's absolutely sufficient. It's a 100% surrogate marker for the P53 mutation. Just that we have to assess it accurately. It should be diffusely and strongly positive in more than 80% of the tumor nuclei. That is the mutant type expression, and it has to be assessed in that particular way only. Wild type expression is less than 50% of the nuclei showing positivity. So that is to be taken as negative. Okay.
All right. Okay. Thank you. Now, this is the paper again specifying the importance of clinically classifying the endometrial cancers and into these 4 groups as per the molecular classification, having prognostic and treatment guiding information. This is the final. This is another paper I found out in published in 2020, which shows again as per the Dr. Jaya's talk and the esteemed panelists as she said, that we should divide the endometrial cancers in POL mutated, MMRD, non-specified molecular profile, and P53 mutation categories as of now.
Can I just make one point?
Yes, ma'am.
So while we are doing, POLE is done in hardly any center in our country.
Yes, ma'am.
Okay, but MMRD, of course, can be done in good centers. Apart from that, I think we need to sensitize our pathologists that this new thing has come up in this ESMO-ESGO paper about the LVSI, which again prognosticates. So it is important that they should tell us whether the LVSI is negative, focal, or diffuse, because that also prognosticates the disease.
Right. So I'd like to ask Dr. D.N. Sharma, sir. In clinical practice, have we started incorporating the molecular classification to stratify endometrial cancer patient in these risk groups?
Thank you, Abhishek. Am I audible, by the way?
Yes, sir, you are.
Okay, fine. So honestly speaking, as of now, we have not incorporated the molecular classification for the, deciding the adjuvant treatment. Our treatment is still based on the clinical factors and the pathological factors, mainly the biometric invasion, the grade, LVSI is and other factors. So maybe we need to have some more data before we incorporate this into the practice. But as of now, we are not considering the molecular markers for deciding the adjuvant treatment.
Umesh, sir, what about TMH?
Thank you, Abhishek. So what we have done in TMH is over past few years, we have been doing, let's say, estrogen progesterone receptors to classify them into pure endometrioid and type 2 histology. The second thing is we also now ask for P53, which is very easily done. So indirectly, we are trying to implement in a let's say not systematic way, but the markers which can help us to identify the type of histology and prognosis of the patient. So these are being implemented in TMH for a couple of years now.
For all endometrial cases, sir, or only for high risk cases?
No, if it is endometrioid adenoCA, then we do ERPR for sure for all patients. And there is some data now for HER2/neu also, but we have not yet implemented because that has implications of treatment again. Whereas for type 2 histology, we are trying to do P53 mutations so that we know we can give an aggressive treatment for these patients who are P53 mutated.
Right, sir. So as far as the commonly used guidelines are concerned, this is NCCN version 2021, in which as of now, I don't think they have incorporated the molecular classification. This is that paper of 2016, combined guidelines by ESMO, ESGO, and ISTRO. Again, they've classified, but that is of 2016. They've classified high risk based on only histopathological features. Sharma sir, what should be the adjuvant treatment and sequence in this particular case? Serous carcinoma, 1B, more than 60 years old.
Okay. Our protocol for these kind of tumors is a sequential chemotherapy and radiotherapy now, in a sandwich fashion. We first give 3 cycles of chemotherapy, Paclitaxel carbo, and then after 3 cycles, we give the radiation treatment to the pelvis with vaginal brachytherapy, and then followed by 3 more cycles of the chemotherapy. So that's the sandwich protocol which we are following, which many people follow now. We are not following the concurrent CTRT protocol, as per like POTAC or GOG. So that's the treatment which I recommend for this patient.
Right, sir. Right, sir. Umesh sir, are we following this POTEC 3 paper? Protocol in TMH, the concurrent chemo radiation followed by chemo.
Yes, before POTEC 3 final results were out last year, we were practicing for all these high risk type 2 histology, adjuvant chemo radiation. And of course, the sequence was very difficult. So over almost 6 months, we sat with medical oncologists to find out what is the best option for these patients, because obviously, say for example, in this case, if it is P53 mutated serous histology, these patients definitely benefit from a combination of both adjuvant chemo and radiation. So we were debating a lot on what should be the sequencing, and what we came to a consensus sort of was that post-operatively, we will offer them 4 cycles of Paclitaxel, and then we offer them pelvic radiation. And in this, the compliance to both the treatment was more or less, let's say, acceptable. But with POTEC 3 last year coming, we are pushing patients for concomitant chemo radiation followed by adjuvant chemo. But having said that, we have to be very careful in implementing this logistically, because obviously grade 3, grade 4 acute toxicities are quite high with this protocol. And if you see POTEC 3 as well as GOG 258, concomitant chemo radiation protocol, as compared to radiation alone or as compared to chemotherapy alone, the toxicity definitely is higher with this protocol. So we need to be very careful in implementing this POTEC 3 protocol. Especially when you want to treat an extended field if patient merits by virtue of stage 3C2 retroperitoneal node positive on dissection.
Right, sir. As far as the POTEC 3 molecular classification, POTEC 3 molecular classification subset analysis showed us that already being discussed by Dr. Jaya, the pol mute patients behaved really well in both the terms of overall survival and relapse-free survival, and it was significantly different than P53 abnormal tumors, and ours is a P53 abnormal case. So, and the recent paper of with combination of ISTRO, ISGO, and European Society of Pathology guidelines also recommend that we should follow the POTEC 3 guidelines. But obviously, many centers have not adapted to it yet because of the toxicity concerns. Umesh sir, you just told that whenever we try to use extended field in these patients, it's all the more a problem, of course, to use concurrent chemo. So should paraortic lymph node region be included in target volumes in these high-risk serous cases? And what do we have to do different in external and brachy planning in these cases, actually?
So as I said, if the staging has been adequate in terms of dissection of pelvic nodes and sampling of paraortic nodal region, and if patients have disease extending into paraortic, I would definitely go for extended field radiation, even if it might come at the compromise of, let's say, 15 to 20% of the chemotherapy schedule. We should try and push, because these are type 2 histology aggressive tumors. We should be aggressive in treating these patients loco-regionally. And for what I didn't understand the question, what do we have to do different in external brachy planning? I think brachy boost may or may not be offered to these patients. I think the only indication for adding brachytherapy in these type 2 histology in this case at least would be if the cervix was involved. If it is stage 2, then brachytherapy boost may be offered. Second is if the vaginal cuff is inadequate and margin is close or positive, as I think in this case you had a very close or positive margin, we would also give a boost of brachytherapy, treating top 3 to 4 centimeters only.
Okay, sir. Right, sir. And what has been your experience regarding this concurrent schedule, concurrent chemo radiation schedule, which you have been practicing? How do the patients tolerate it?
So I have moved out from Tata Hospital to the another unit of Tata Hospital in Visakhapatnam now. So last 1 year, we have treated 5 patients of patients with the POTEC 3 regimen. I must admit that as a radiation oncologist, we have to be a bit careful because it is obviously a combined modality treatment. We should always think about how patient would tolerate the next line of treatment. And keeping that in mind, you should plan the patient. Otherwise, what will happen is everybody think, oh, it is my turn now to treat the patient. I will treat the way what I want. But what is important for patient outcome and compliance would be that think about the next modality which should be offered to the patient, and keeping that in mind, you should plan your treatment. Having said that, out of these 5-6 patients, 4 were pelvic radiation and 2 were extended field radiation. And in fact, yesterday I saw the extended field patient after a year of treatment, and she's doing really fine. Actually, a serous histology itself. So I think it is important that the physicians be vigilant, whatever treatment is being offered, whatever sequence is being offered. For example, if medical oncologist is giving chemotherapy upfront, be careful. If this patient has toxicities, it means this patient has low bone marrow reserves, then you should have a discussion with radiation oncologists and say this patient may not tolerate or may have poor compliance to completing chemotherapy or reduction in the doses. What it means is it will compromise the systemic therapy. So in such situations, we should work together and come up with a comprehensive treatment plan for every patient we see.
Right, sir.
Abhishek, you have just a little time, almost finished. Huh?
Yes, sir.
Very quickly you can do it. Yeah.
I'm on the last question, sir. So our case, we treated with POTEC 3 protocol. We could manage to treat. She was a very good patient, good performance status. And we gave brachytherapy boost as well. Dr. Satinder, how do we follow up these high-risk endometrial cases? What imaging and what frequency should we do to analyze, to keep the patients on follow-up?
So follow-up remains the same as for all endometrial cancers, and usually we do an ultrasound every 3 monthly for first 2 years, and then we go to 6 monthly for next 3 years. And if there is anything suspected on ultrasound and or clinically, you have said there is clinically no evidence of disease. So clinically, I am assuming patient is normal. So if there is nothing clinically and ultrasound is normal, we normally do not do anything else. But if there is some suspicion on clinically or ultrasound, we go in for a CT scan for the next investigation.
Right.
Can I just add one small point? See, this was a serous histology. So whenever, for us, for serous histologies, we do like to do a CA125 as well. We have seen a few cases who have come back to us, recurred, and we've got the recurrence just by a raised CA125.
Okay, ma'am. Very valid point. Thank you, ma'am. I think I am done with the panel discussion. If anybody has any questions, Dr. Aditi, are we open for taking questions from the audience?
Dr. Abhishek, maybe we can take one quick question and expert comments from the chairpersons.
Yeah.
So we do have a few questions in the chat box.
Mm-hmm.
I think few of them have been answered.
I'm not able to see the chat box. Can you please read them out?
Okay, so one question was, I think this is related to Dr. Supriya's talk. How do we weigh the risk of developing fistulas to the control rates or palliation achieved for an advanced cervical cancer, even with the technological advances?
I think that's out of the panel discussion purview.
No, that's not for the panel discussion. I mean, it's for the entire session. So that's, I think, related to Dr. Supriya's talk.
Okay.
Yeah, if Supriya is on, she can answer that quickly.
Yes, so basically case selection is very important. So there will be different varieties of patients. So we are talking of patients where they come back with a recurrence, which is possibly not good enough for surgery or brachy salvage, but good enough to be given external radiation. So typically, even if you do brachy or even if you do external radiation, toxicity in these patients, the ballpark figure is 25%. 1 in 4 patients will develop a fistula or toxicity. So the way I counsel patients is that if you have upfront exentration, anyway, you are going to have stoma day one. So if you re-irradiate, there is 1 in 4 chance. So it's a value judgment both for the physician and patient. Thank you.
Aditi, I
Sir,
think there was one question for Dr. Jaya. She want to add something to that. Aditi,
sir,
you
one
can read.
question. Yes, sir. So one question is, do we use the classification to tailor therapy as of now for carcinoma endometrium?
I think the verdict is still not on. The classification, molecular classification, has been proposed by ESGO, ESMO, and ESGO, ESTRO, and ESP recently. What needs is validation, and then there is an ongoing POTEC 4A, which is based on the molecular classification. So we should wait for mature results of POTEC 4A, especially for early stage, low risk as well as intermediate and high risk patients.
So sitting in an academic center in a research setting, getting the molecular markers done and indirectly using them to decide the prognosis and tailoring therapy is what was discussed. But then out of trial, do we order such tests and do we use them?
No, don't go by this very fancy word of molecular classification. If you sit with your pathologist, it's very easy to implement IHCs. So for IHCs, you already have P53, you already have MMR. So with these two simple IHCs, you can still up to 80% of your patients stratify them into various risk groups. So it is not very difficult. The only hurdle is poly mutated, and you know that. Of course, it is not a big brainer for identifying poly patients, because if there are low risk, early stage endometrioid, many times you can clinically say that this is poly mutated based on the outcome. And poly, the mutated anyways do very well, whether you give adjuvant treatment or not. So I would say that it is very easy to implement this molecular classification. It's just a matter of attitude and implementing the refined techniques to triage the patients and give maximum benefit in terms of avoiding therapies, improving the quality of life without compromising the outcome. And if that is the key end point, then definitely for every patient, you would try and work hard to implement that.
Yeah, definitely. I think with time, this will become the standard of care.
Right, sir.
Right, ma'am.
Thank you, sir.
So, Dr. Aditi, this session is coming to an end, right?
Right,
Yes,
sir.
sir. Right. And I must congratulate Abhishek for a very patient conduction of the expert panel discussion. Very coolly is conducted. Congratulations, Abhishek. And both the speakers for being excellent and updating us on the latest data. And all these, I must say that molecular markers, they do help us. You know, once in a while, you see a patient who is not responding or who should have been treated otherwise, then you are, into a fix. And if you have done some kind of molecular marking or mapping, it definitely helps you in deciding the treatment for these patients. And cervical cancers, we have been treating them for so long and we are still improving, and the technology is playing a part, especially the extended field radiation. So thank you, Aditi, for being there, and thank you, Paras Group of Hospitals, for inviting us. Dr. Srivastav, thank you, sir.
Thank you. Thank you.
And my co-chair, she wanted me to introduce somebody, but I couldn't take the orders. Sorry, ma'am. And I hand over you to Dr. Aditi. Thank you, sir.
Thank you, Aditi, and thank you, Abhishek Anand. It was really a wonderful session. All 2 lectures and the panel discussion was very interesting. And all the panelists and the lecturers congratulate for a good work which has been done. And thank you. Thank you very much. And thank you for all the organizer of the Paris conclave.
Thank you so much, sir. Thank you so much for the nice words.
Thank you very much.
So moving ahead with the next session, I will request chairperson for the next session, Dr. Rama Joshi. She's a gynae oncology surgeon, robotic surgeon, director of Department of Gynec Oncology and Robotic Surgery, Fortis Memorial Research Institute, Gurgaon. You are there, Dr. Rama Joshi?
Yes, I think.
Dr. Temfor Clements, who is the MBA Clinic Director, University Women's Clinic of Ruhr, University Bochum Marian Hospital, Herney. And Dr. R.N. Tagore, he is a Senior Consultant Medical Oncology at Paras Cancer Center, Patna. So over to you, chairpersons. You can call upon the next speaker for the session.
So welcome you all to this interesting session of ovarian cancer. And I think this session we have two interesting talks. One is on the intraperitoneal chemotherapy in epithelial ovarian cancer. Other is also addressing the issue of maintenance therapy in ovarian cancer. After this, we will have a very interesting panel discussion. So we invite our first speaker, Dr. Vinay Gayakwar. Dr. Vinay Gayakwar is the Associate Director in Head Surgical Oncology, and he's going to deliver his talk on the intraperitoneal chemotherapy in epithelial ovarian cancer. Over to you, Dr. Vinay.
Thank you so much, Dr. Rama Joshi. It's a pleasure to have you chairing the session. I want to thank the organizers, Dr. Rangarao and Dr. Aditi and the other colleagues. So without any delay, I'll start the session. I hope you can see my slides.
Yes.
Yeah, so we'll start. So just a brief compilation of some data on intraperitoneal chemotherapy for ovarian cancer in specific. So as we all know, most of recurrences happen within the peritoneal cavity in C ovary. And in India, unfortunately, most patients present in the third or fourth stage. I hope that will change soon, but as of now, that is still true. So if we can remove Graves' disease by CRS, we hope to eradicate microscopic disease by HIPEC. That's in a nutshell. So the utility of HIPEC could be either in the primary, interval, consolidation, secondary, and even sometimes. Can you hear me?
Yes, we can.
Yeah, okay, so even in the palliative setting. So these are some of the procedures that are done during a cytoreductive surgery in ovarian cancer. Many times there have to be multi-visceral resections if the PCI is high. Peritoneal lavage is something that we routinely perform, and at least a selective peritonectomy. So for some of us who are not aware of HIPEC, we understand why we perform HIPEC with the pharmacokinetics. Heated chemotherapy can penetrate tissue up to about 6 millimeters. The heat itself has anti-tumor effects, and it can help make platinum sensitivity happen through the drug mechanisms, and can penetrate because the drug does not penetrate the plasma peritoneal barrier. There are less systemic adverse effects. So there are many drugs being used, the most common among them being cisplatin, carboplatin. There are a few centers using other drugs as well. But right now, the appropriate drug is still not completely, there's no common consensus exactly as to the drug. Now, coming to the quality of life index, I think there's enough studies showing that there's a acceptable quality of life after HIPEC in stage 3 ovarian cancer and so on. There are meta-analyses for HIPEC in ovarian cancer, which has shown that HIPEC is associated with improved overall survival as well as progression-free survival in primary as well as recurrent ovarian cancer. But it adds in this meta-analysis that the 1 and 2 year progression-free survival has not been reached in recurrent ovarian cancers. But I'll just show you a study that just got published in the Lancet Oncology. It's a Chinese group that has shown progression-free survival. So there are studies comparing CRS and HIPEC versus CRS alone, as well as CRS and HIPEC versus systemic chemotherapy. Now, these are some of the few trials on in the primary setting. I won't go into the details for the lack of time, and there are many trials in the recurrent setting, some randomized, some not randomized. But overall, I think there's very promising data regarding CRS and HIPEC in ovarian cancer. In the interval cytoreduction, I think we have almost level 1 evidence. So I think most of us are convinced about performing a CRS and HIPEC in the interval setting. I'm sure most of us will agree on that. So this is a study that recently published. It's a Chinese study published this year, just recently in this month, in fact, in Lancet Oncology. It's a multi-centric randomized study about secondary cytoreduction, relapsed platinum-sensitive epithelial ovarian cancers, chemotherapy versus, CRS and HIPEC versus chemotherapy alone. And it has shown significant progression-free survival. That's the primary endpoint. So this is our series. I'll just go quickly. So I want to show you a small video about the CRS and HIPEC. This is not a patient with ovarian cancer. This was performed about 6 years ago for pseudomyxoma, but just for you to get an idea about what it's all about. So this is quite a high PCI, but at about 25 or 26 PCI, the peritoneal carcinomatosis index. So we started off with a large incision from symphysis pubis to the xiphisternum. Start with removing the peritoneum en bloc as much as possible before entering the peritoneal cavity. You can see, pseudomyxomas are pretty gross looking, lot of mucinous material which has to be evacuated. A lot of serosal deposits, mesenteric deposits. So it's pretty painstaking. It takes a lot of time, but especially in low-grade tumors like pseudomyxomas and low-grade even ovarian cancer, it's very, very fulfilling, and it's worth every minute you spend on the cytoreduction. So this is some of the tumor being taken out from the stomach, also from the so some part of the bowel that is this extensive disease. It might be worthwhile resecting that bowel and performing an anastomosis. In this situation, we performed 2 resections of the small bowel as well as the rectosigmoid. So because it was just too extensive to think of doing cytoreduction. So the glycinectomy from the liver, diaphragmatic stripping, all is something that requires some training and expertise to avoid complications. Then the anastomosis can be done either after the HIPEC or before the HIPEC. Many prefer to do it after the HIPEC to ensure the anastomotic line comes in contact with the chemotherapy. So after that, after the extensive cytoreduction, you can see that it's virtually CC0 at the end of it. And after that, the installation of the chemotherapy is started. Initially, we used to use the Belmont machine with the temperature probe attached to the inflow and outflow catheters. We have switched now to a RAND machine, but this was an earlier case. So we use a closed technique routinely. So I'll just move on. I don't want to take up too much time. So it can be done either through the closed technique is what we use, or the open Colosseum technique, which the abdomen is left open and the chemotherapy is then instilled. So this is the Belmont machine. We've also used a thermal solution machine, but we've finally settled on the RAND machine, which I'm sure Dr. Rama Joshi will also agree that is something that this machine seems to be something we prefer. I think even she uses the same machine. So future directions, there's a lot of talk about intraperitoneal immunotherapy. That's something that I've been thinking about. I recently had a patient who wanted one of these, but I didn't have the evidence to support using it. The other thing I just want to brush by is PIPAC, which we are routinely performing as a palliative technique when it's just too high a PCI or this platinum resistant disease. It can be used. It's a straightforward procedure, laparoscopic procedure, in which 2 ports are introduced laparoscopically, and then the chemotherapy is kind of aerosolized with a special capno pen, a pen that converts the liquid into a gaseous form, and that is kind of left to sediment in the peritoneal cavity for about 30 minutes. So there are many studies that have been done and are still ongoing to support its role in palliation. So to conclude, there are many ongoing phase 3 trials on CRs and HIPEC in C ovary. Accurate details are still evolving, but we have a lot of data already, and I'm sure HIPEC serves a complementary role in successful CRS and appears to improve survival. Thank you all for your attention, and I'll pass the ball back to the chairpersons.
Thank you so much, Dr. Vinay. It was an excellent presentation. I think we will have the talks earlier, and if the time permits, then we will take up the questions.
Thank you. Dr. Aditi, I think it's we move to next session. Yes, ma'am. Thank you.
I think the next speaker is Dr. Rajeshwar Singh from Panchkula, and he'll be delivering his talk on maintenance therapy in advanced ovarian cancer. Dr. Rajeshwar Singh is the Director Medical Oncology.
Thank you, ma'am. I'd like to share my slides. Can you? Okay, can you share my slides? There is some problem with this slides. Organizer, please share my slides. Yeah, good evening, everyone. I know we are running late and I'm part of the organization.
Backend team, please, can you share the slides?
Not like to delay any of you. Please share the slides. So basically, I'll, I think, start speaking because time is very less. So basically what it is that in ovarian cancer treatment, especially the first line treatment, in India, we have a problem because that we know that patient come very late to us in stage, mostly in stage 3 and 4, large disease, large ascites, surgeries.
Sir, now you can see my slide.
Yeah. Next, please. So this is the scene we have, the 90% relapse within first 3 years of treatment, and 5-year survival in a very good centers is about 30%, 38%. So we need to do something to prolong this disease-free survival, prolong this survival without disease for some time. So we tried many things. Many things were tried in form of maintenance or in form of paclitaxel, maintenance of bevacizumab, erlotinib, and many more. And we were not successful. Next slide, please. And then came this GOG iconic, this trial came, 218 trial, where standard paclicarbo was combined with paclicarbo bev during the treatment only, and then with the treatment and maintenance. But the bev used was 15 milligram per kg IV. Next slide, please. And initial PFS, which was done, which shows there was an advantage in PFS. Next, please. However, the overall survival that time did not show any, the hazard ratio was not 1.036, so it did not show any advantage. Next, please. And the adverse event, we know that bevacizumab standard adverse events were there in form of hypertension, proteinuria, thromboembolic events, and wound healing problem. Next, please. And so in this, when overall survival was subgroup analysis was done, they found in stage 4, who were treated with both primary as well as in maintenance, they had a hazard ratio of 0.72, which was significant. So what it showed was that in a patient of stage 4, there is an advantage of doing giving BEV during primary as well as in maintenance treatment. And a patient with ascites, they also saw some PFS advantage, though overall was less. So this trial, what it showed was that basically in stage 4 disease, there was an advantage of giving bevacizumab both with the primary treatment as well as in maintenance. Next, please. Now, then came the second trial, which was the ICON 7 trial. In this, there is a difference in this that they use bevacizumab only 7.5 milligram per kg body weight. And carboplatin was also used AOC 5 or 6. And they have given only for 12 additional cycles. So next, please. And initial PFS was not significant, only 2 months advantage. Next, please. Next slide. And even overall survival was not different to that. Next, please. Next. So when subgroup analysis in this also done, they found in stage 3, which was suboptimally cytoreduced, in stage 4 cancer and high risk, which are marked by red color, they had all advantage in overall survival also, with hazards 0.78, 0.76 and 0.84. So in these diseases, this was advantage of using bevacizumab. Next slide, please. And the final PFS analysis which came out, this showed that the hazard ratio was significant, 0.73 with a p-value of 0.001. So this showed that in a high risk, that is stage 3 suboptimal debulk, stage 4, and in which no debulking surgery done, in these patients, it was better to use bevacizumab. Next, please. And in overall survival also, there was a survival advantage of 9.4 months in this. So this proved that these two trials have proven that bevacizumab should be used in these high-risk group, stage 3 suboptimal debulk or stage 4, or where no debulking surgery is done, to use bevacizumab with primary treatment as well as in maintenance. Next, please. And you see the stage 4 disease, normally stage 3 suboptimally reduced, in which the bevacizumab is given, the overall survival, median overall survival goes to 42 months, whereas it is in stage 4, it is 32%. But when we use bevacizumab, next, please. Next, it increases from, back, please. It increases the survival from 32 to 42 months, which is equal to in what is there in stage 3 diseases. So that is the advantage of giving bevacizumab in this. Next, please. So the difference between these two trials was, one, the dose was higher, number of cycles was much higher. And because in GOG 218, the problem was that only 24 to 24% could get treatment beyond 22 cycles. Whereas in ICON 7, the dose was less, even carboplatin, some 5 or 6 you could use. So 62% higher number of patients could continue beyond 18 cycles. Next. So if this is an NCCN guideline also, where paclitaxel you can, and the standard chemo carboplatin paclitaxel you can combine with bevacizumab with a 7.5 milligram per kg body weight, as per ICON 7 or GOG 218, where it is given as 15 milligram. I preferred 7.5 milligram, where toxicity is less, and also the AOC is of carboplatin is 5 is used in that. Next, please. So after the bevacizumab established the role that came the PARP inhibitor in the maintenance therapy in the newly diagnosed ovarian cancer. Next, please. As we know that PARP, the single strand DNA break keep occurring all the time. Back, please. And the PARPs are required for repairing those. If they are not repaired by inhibitors, the replication occurrence, double stranded breaks occur. Normally, these breaks are they are repaired by homologous recombination. When there is a deficiency of HRD, so the cell death occurs. This is called as synthetic legality, both pathways when they occur simultaneously together. This is how the PARP inhibitors, they work in ovarian cancer, in BRCA mutated cancer. Next, please. So for that, once one trial was done where olaparib versus placebo in high-grade serous or endometrial cancer, who had after surgery, they had responded either with CR or PR to platinum-based chemotherapy. They were randomized to olaparib versus a placebo, and it was carried on for 2 years. And the primary endpoint was PFS, and secondary PFS to time to second treatment, overall survival, and quality. Next, please. And here you see the PFS you see in this, the 56 month. I mean, for 5 years also people were taking treatment in this, as compared to the placebo, which was 13 months. So difference was 42 months, and with a hazard ratio of 0.33 means that 67% reduction of risk in this. Next, please. And patients were taking treatment for a very long time also, even more than 2 years, olaparib was being given. Next, please. And you see that 47% patient could they completed treatment at 2 years as per protocol. And rest, you know, as we know that patient will progress, adverse events are there, some amount of another unknown reason which was for which it was stopped, but still 47% could carry on for 2 years. Next, please. So second trial was done with the niraparib, was the primer trial, where here again high risk, high grade tumor was all tumor were high grade was taken, and BRCA was subsequently done. They were from general population, and they were who had responded to platinum based chemotherapy to niraparib versus placebo. Primary endpoint PFS. Next, please. And in a HRD patient, you see the median PFS was 21 months and placebo was 10 months. So there is a hazard ratio of 0.343. So, and they found that about 48% to 50% had either HRD or a BRCA mutation. Next, please. And when they saw between the HRD and overall population, so HRD definitely the hazard ratio of 0.43, but too surprisingly in overall population also the hazard ratio was 0.62. Next, please. And here you see the HRD in BRCA mutated, which was hazard ratio was 0.40, whereas in wild type HRD positive, but wild type BRCA, it was 0.50, which was very good. But even in HR proficient, that this is the first PARP inhibitor which has shown the hazard ratio of 0.68. That is, there is a benefit of using niraparib in all the subgroups. Next, please. And if we compare both the BRCA 1 and 2, almost equal effective drug in both the BRCA 1 and 2 mutated cancer. Next, please. So all subgroup, even those who had received neoadjuvant chemotherapy, hazard ratio was 0.59. Who had a PR initially as a best response to first line, they had a hazard ratio of 0.60. So all subgroup they benefited from this. Next, please.
Dr. Rajeshwar, if suppose you can wind up, please.
Yeah. So safety profile was okay. Next, please. So we can give niraparib regardless of HRD across all group. Next, please. So in maintenance, there's olaparib as well as bevacizumab trial which was done. Next, please. This has also shown that the hazard ratio of 0.59. Next, please. And about 50% were HRD positive. Next. And they benefit both HRD positive as well as BRCA positive, but they did not benefit who are HRD negative or unknown. So these combinations not for BRCA negative tumors. Next, please. Side effect profile is higher number of patients as side effect. Next, please. Go on to last slide, please. So even this pazopanib as well as nintedanib was tried in AGU-AOR 16, and they found that PFS was improved, but there was no improvement of overall survival. Next, please. Please keep next. In fact, in Asian population, it was deleterious the effect of giving this drug. Next, please.
Can you wind up, please?
So pazopanib as an nintedanib is not given. If so, we want to give in first or second line, you should give in first line because the 36-month advantage is there. So all BRCA mutated patient or HRD positive should be given PARP inhibitor or BEV or PARP inhibitor. There is no one correct answer that apply to all patients. We have to discuss with the patient. There is no head comparison with this, and BEV as well as PARP should be given to all HRD positive. Thank you.
Thank you, Dr. Rajeshwar. You presented very well, and I think the importance of the bevacizumab as well as the olaparib as the targeted therapy seems promising in the maintenance setting in advanced ovarian cancers. So I think both the talks had been wonderful, and Dr. Vinay had really made up a point that this is the time when we are looking at the peritoneal control of the disease as well as the survival, though we have got only level 1 evidence in the interval surgical cytoreductive setting for the advanced ovarian cancers for the HIPEC. I think we need to have more trials so as to perform the the upfront HIPEC. So I invite now the moderator of the session of the panel discussion, that is Dr. Ghansham Vishwas. He is a medical oncologist at Sparsh Hospital AOI, some hospital, Bhubaneswar, Orissa. Over to you, Dr. Ghansham, for the very interesting panel discussion we all are looking forward to.
Yeah, thank you, ma'am, and thank you, the Bharat team. Since I have been allotted 15 minutes, I hope my all panelists are there. So these are all esteemed panelists, so medical oncologist, surgical oncologist, and there is a gynec oncologist also. I don't know. So what happened?
Sir, it is inaugural which has to start now. I think.
Hello.
Inaugural.
Hello.
I think the panel discussion will be
supporting. Kindly continue with panel discussion.
Okay, ma'am. Okay.
Okay, fine. Kindly share the slides, please.
Let me start.
Please allow me to share the slide.
Share the panel discussion slides, please.
Please stop sharing this, no? So I can share my slides.
Ghanshyam, please concise the.
Sir. So this is 65-year female with pain, abdomen, discomfort, no comorbidities, no positive family history. CT scan revealed a right complex ovarian mass with omental deposits and ascites. Endoscopy was normal. Again, same thing. Somebody is putting the inaugural slides. I don't know.
I think maybe you can just continue with the history in any case.
Then how do I present? No? Is there somebody? I don't know.
Can the organizers kindly look into that this inaugural slide requires to be removed? Yes.
So endoscopy was normal, high CA125, CA is normal. TAH and BSO ammontectomy. I don't know. So again, same thing.
Dr. Vishwas, you continue speaking. We are listening.
Just the slides are going away, no? So how do I speak?
Doesn't matter.
I think you can see that.
From your own system, maybe, yeah.
So so TH, BSO ammontectomy was performed by a gynec surgeon, so not an oncosurgeon, not a gynec oncosurgeon. So bilateral ovarian tumors found nodular omentum and 1.5 centimeter paracecal mass was removed. Histological grade 3 serous carcinoma ovary with disease in omentum and peritoneum was seen positive. So to my surgeon colleague, Dr. Piyush Agarwal, so would you like to have a completion surgery?
Sir, first thing is that I do not have the complete information regarding the metastatic workup of the patient. So what I can see is only the disease in the abdomen, which is actually ascites is present. There are deposits. I am not exactly sure of how much the disease is there. So first and foremost, I need that information, how much disease is there. Secondly, we don't have any metastatic workup with ascites or mental deposit. If there is metastasis to some other part or there
is no outside the abdomen, no?
No
so
outside, nothing outside.
This is the scan post-surgery. So you can see that residual outer cover node.
So sir, basically I would like to assess the patient for complete primary cytoreduction. If I find the patient adequate for complete primary cytoreduction, I will go for complete primary cytoreduction. If I think the patient is not fit for an R0 resection, if I find it, then I will basically send the patient for neoadjuvant chemotherapy followed by interval cytoreduction with HIPEC.
So I move to my medical oncologist, Dr. Sachin Gupta. So what will be your systemic therapy plan in this patient?
Yeah, so of course, so there is no disease above the diaphragm. I would involve my oncosurgeon friend and have a discussion regarding, possibility of a repeat surgery. But, normally, another surgery, etc., becomes very difficult and cumbersome for the patient.
Right.
And practically speaking, we do go ahead with, chemotherapy, adjuvant chemotherapy in such a scenario.
So what will be your choice? Be precise. So what will be your choice?
So can I just intervene for a while? Just put across a point quickly. The thumb rule is that if the patient comes to you, such a patient comes to you, you do a CT scan, assess the disease. If she comes to you within 6 weeks of the first surgery, you can definitely go ahead and do a completion surgery. But if she comes to you after 6 weeks, definitely one would want to do neoadjuvant chemotherapy first, followed by interval site reduction and adjuvant therapy.
Yeah, Dr. Sandeep, so what will be your systemic choice here?
Ghansab, is the node was positive?
Nodes are positive.
Yeah.
Yes, any medical oncology colleague? Dr. Rajat? Dr. Munish? No. So this was the residual outer cover node. So this was the, you can see the Lion phase 2 trial. So lymphadenectomy for a lymph node negative advanced ovarian cancer following complete dissection published in NEGM. So we see no difference in a stage 4. So lymphadenectomy versus no lymphadenectomy. So these are systemic choices. So standard, we know that Paclitaxel carbo, and you can add bevacizumab. We have heard from the previous talk also, based on GOG218 and ICON 7. So dose dense paclitaxel, we are not practicing. Fractionated paclitaxel maybe in patients who are frail or a low albumin. So this patient received a standard paclitaxel and carboplatin 3-weekly schedule. So my medical oncology colleague, Dr. Sandeep, is there? Oh, he's not there. Dr. Mudesar?
Sir. Yeah, I'm here.
Yeah, so suppose some patient gets a Paclitaxel hypersensitivity. So do you change the protocol?
Sir, in that instance, as you have put it, this PLD and pattern-based therapy. So we have data regarding paclitaxel plus carboplatin considered as standard primary chemotherapy all the time. But in patients who have significant hypersensitivity with paclitaxel, we may go with an alternate regimen.
Yeah, so this is a recent meta-analysis of 7 studies of around 4,000 patients. So they have shown that PLD carboplatin is relatively less toxic, so no allergy and no neurotoxicity. So otherwise DFS remains the same, so no OS benefit. So are you going to add bevacizumab and Dr. Sachin?
So yeah, so according to, as we have just discussed, GOG218 and also ICON 7. So addition of bevacizumab does give benefit, but we'll have to, add it according to the surgical timing also.
Okay, so now, so suppose it is post 8 weeks now, so you otherwise you may skip in the first cycle. So what do you practice, GOG218 or ICON 7?
ICON 7 actually, for just ease and the dose and the cost issues. And so I most of the times try to stick to ICON 7. That becomes more feasible for our patients.
Yeah. So
just
cost
for
wise also,
feasibility sense. Yes, it makes a lot of cost sense also. And but we have to keep a gap of 6 weeks from the surgery, and accordingly the doses have to be used.
Right. So we know that in advanced ovarian cancer first line, so we have a modest response rate, PFS, but again, we are really striving hard for the OS. So with bevacizumab, so you can see, so the PFS benefit is there, probably in stage 4 disease, we have some OS benefit, otherwise, so with the generics available, so toxicity, the cost is taken care of. So any takers for opinion on the HIPEC, though we have completed one, so we can go back to Dr. Piyush Agarwal. So any opinion on HIPEC and IP chemotherapy?
So, sir, current data basically and NCCN guideline also basically recommend using HIPEC when we are doing secondary cytoreduction post neoadjuvant chemotherapy.
Right.
After HIPEC, definitely NCCN guidelines don't recommend, but significant data with a lot of meta-analysis have been coming. Plus now HIPEC 2 trial is going on currently for seeing the benefit of upfront HIPEC. But definitely in patients who are post neoadjuvant chemotherapy, HIPEC is definitely in. It gives definite survival advantages as well as overall survival plus PFS both, almost to a tune of 1/3 of basically that extra that we can have by only cytoreduction, secondary cytoreduction.
So these are the Korean trial, which was not positive, as Dr. Agarwal said. So the Dutch trial was positive. So Dr. Sekho, so in your institute, do your medical oncology practice for the IP chemotherapy?
We did do quite a number of cases with IP chemotherapy, but subsequently the patient used to have so many bowel symptoms and so many adverse effects, so we just gave up IP chemotherapy. We no longer
so that works probably better.
We are
when
doing
the
a lot of
HIPEC,
HIPEC, but not any intraperitoneal chemotherapy. It requires a special
so these are all
setting, dedicated oncologist and all that. It's not so easy.
So Dr. Sachin, so what you order as a molecular investigations?
Actually, we are now switched to, we are no more discussing HIPEC here.
Sir, we have only 7 minutes left.
Okay, actually, I was going to make a comment. I'm glad Dr. Sekho mentioned that. And so we have a lot of, so when I was at RGCI also there, that time also we tried to do. And so, of course, with complication rate and all, we couldn't continue much. So we need more of, centers where this is taken up as a, and for a lot of time, we need to gain experience in HIPEC before we say our institutes can practice this.
So maybe Dr.
Coming to molecular,
1 minute.
so I would like to.
Sorry, Sachin, to interrupt you. We are doing a lot of HIPEC, but we are not doing any intraperitoneal chemotherapy.
Yeah.
Yeah.
So HIPEC thing again, we have to learn more and more. Yeah.
But not IP chemotherapy. HIPEC
absolutely.
Advantage.
That's right.
Som Shekhar probably at Manipal, he did a lot of HIPEC, no?
Yeah.
We were the pioneers actually for doing HIPEC, and we have already presented it at IGCS, where we presented 145 cases of HIPEC, where the HIPEC was done in a recurrent setting. So now we, of course, we are doing entirely in interval debulking setting, and hopefully we should have some data to present in a year or so.
So results.
HIPEC is only limited to the metro city and very selected center.
Yes,
so I think
that is true.
Sir, but it is now coming up in small cities like Bareilly and other centers also. Few of my friends are definitely doing it. Ranchi, Bareilly, small centers are also taking up HIPEC because the machine availability is now there. People are getting trained to do it.
Yeah, hoping in coming year,
actually, sir, the thing is, in HIPEC, what you need is a cytoreduction, proper cytoreduction, which already surgeons are doing in the small city. HIPEC is only just instilling chemotherapy, which basically can be done by anybody. It doesn't require much of a technical expertise. So the technical expertise is in proper cytoreduction. So that already people are doing.
Absolutely, I agree with Piyush completely. The expertise is required for an optimal cytoreduction. Otherwise, HIPEC is basically you just need a pump. You can improvise it yourself. You just need a pump so that chemotherapy, heated chemotherapy is circulated. And in fact, there are some people who are also doing HIPEC, not HIPEC with hyperthermic, but with the normothermic chemotherapy. They're circulating in TROP and they're waiting for the results. Somebody in Bangalore is doing that.
Yeah, ma'am, can I move to the molecular part? So, Dr. Mudesser, so would you like to order any more investigations? I mean, molecular. And what is your usual practice?
At point, yes, I think at this point I would go for at least BRCA 1 and 2 mutation or that help me in deciding about the major therapy.
Right. So the PARP inhibitors are the Achilles heel. And we know that there are biomarkers for PARP sensitivity. So BRCA mutations can be seen more in the high grade and in the HRD deficient. So degree of platinum sensitivity. So Sachin, Dr. Sachin, so in which patients do you advocate the germline BRCA or a somatic BRCA? So all patients, all comers, all histology type?
I think all patients should undergo a hereditary germline gene mutation testing, and if that is negative, then we should also try to get a somatic mutation testing then from the biopsy block,
right?
And including an HRR. So I'm presently doing from MedGenome, and so we have recently starting doing for all, because earlier these tests were not available and also we didn't have much experience, but nowadays we are ordering for most of the patients.
So I think it's the last 1.5 years. So every of us probably is doing, you are at least trying to do, and many of the companies are supporting us with the tests. So that is the reason that we are probably seeing some positive reports. So these are all guidelines. So even with or without a family history, also you can do the test, advocate the test. So probably the best way to go is the Sanger sequencing. So these are the biomarkers mentioned.
Hello, sir. Hello, sir.
Yeah.
Sir, please conclude, sir.
So today we have already heard about the PARP inhibitors roles. So my patient had a 6 cycles paclitaxel, mild neuropathy. After 10 months, she had a relapse. And
Ghansab, one thing, that is any role of the hormonal therapy if you get the ER/PR positive in ISC in block.
So only the role of hormonal therapy is only for a serological progression. So there is no radiological progression. So we still advocate. We may or may not have the ER/PR positivity, but we still we give tamoxifen, aromatase inhibitors, even at times thalidomide. So these are all for only serological progression.
If the ISC is showing the strong ER/PR positive,
yeah,
in this situation, I think the role of hormone is.
So they are mainly for the low grade tumors, but for high grade tumors, they usually don't respond unless and until we are only probably a serological progression.
Yeah.
So for a secondary cytoreduction, so probably you have to follow these agar desktop performance status, residual disease, and the amount of ascites. So we have these agar desktop 3. So we know that patients who fits into the criteria is benefited with this secondary cytoreduction, but our patient was not good enough. So gem carbo bevacizumab. So let me finish because the organizer are in a hurry. So bevacizumab today can be used in all settings, line settings, clinical conditions, partner. So these are maintenance options of bevacizumab, olaparib with bevacizumab, niraparib. So in summary, germline BRCA mutations they should be offered. So we have seen that the patients who are offered PARP inhibitors in the first line, so they are probably the best candidates. So to conclude, complete resection is the key. Secondary cytoreduction, argyro is important. Factors apart from platinum-free interval important. Taxane and carboplatin still the standard of care. Bevacizumab evidence, is it a holy water? PARP inhibitors data appear strong, especially in the BRCA mutants. Quality of life issues are important because these patients are going to go long. So there are patients who are on 6th line, 7th line, 8th line. Toxicity and efficacy to be balanced. Cost in our country is just a challenge. Thank you. Thank you so much.
Thank you, Biswas. Hello. Thank you, everyone. I think in coming year, IP will be a standard care and emerging role of the HIPEC and the BIPEC. And I hope in our whole part of the country, it will be used. And certainly the role of the maintenance therapy is much more because it is a promise role of the progression-free survival and overall survival. But that is cost content regarding the PARP inhibitors and bevacizumab also in the world-like country. Thank you, all of you.
Thank you.
over to organizer Anand, Abhishek, Aditi. Hello, Abhishek.
Hello. Hi, sir. Support team kindly start inaugural.
Okay, okay.
Ma'am already started on platform.
Please, can you hear me? Is there anyone connected? Hi, thank you very much. I am waiting to start for sharing my PowerPoint presentation. Thank you very much. Mm. Can you confirm that everything is okay? Thank you very much for assistance. Please, can you confirm that everything is okay? Thank you very much for your assistance.
So after a great inauguration session, I think Dr. Aditi has joined here. So moving to the next session, I will request Dr. Aditi Agrawal to take over the session. She is a senior consultant oncologist, radiation oncologist at Paras Hospital, Gurgaon. Over to you, Dr. Aditi.
Thank you so much, Dr. Abhishek. And now moving towards the last session of the day, which is the Meet the Experts session, the much awaited one. We have with us a very distinguished faculty, Dr. Domenico Genovesi. He is the Associate Professor in Radiation Oncology, and he needs no introduction and is well known in radiation oncology community. He has authored a very important and significant book on the delineation of lymph nodal CTV in radiation therapy, which any radiation oncologist would understand that it is difficult to survive without that delineation, and it is read by almost all of us at some point of time or the other. So without wasting any time, I would now like to invite and request Dr. Domenico to please start his talk. Technical team, yeah.
Yes, ma'am.
Yeah, so, yeah, Dr.
Just a moment. I'm trying to share my PowerPoint presentation.
Right, sir. No problem. So if we have any questions, our delegates can post them in the chat box, and we'll be giving your questions to Dr. Domenico, and he will be giving his expert advice on it. So it is very fortunate and a matter of privilege that we have him here.
Sorry, I have just a problem to share my presentation. Just a moment, please.
No issues, sir. You can go ahead. I think he got disconnected.
मैम बाय मिस्टेक वो लेफ्ट हो गए हैं, वो रिजॉइन करेंगे.
Yeah. He'll try to reconnect. Yeah, he's rejoined.
Sir, please open your presentation and PPT slide.
I am searching to launch and to share my presentation from screen sharing.
First, stop your share screen.
Okay. File. Okay.
Dr. Domenico, if there is a problem, you can send these slides to the email ID and we will share it from our end.
Yes, I have a problem to share my presentation. Just
that's absolutely fine. You can mail your presentation to the email ID, Paris Cancer Conclave, and we'll play it from our end.
Sir, first you click open your presentation.
When I try to share the presentation, I see a window.
So you clicked on share screen button, then you see your presentation slide. Then you click on it and share now.
Please, can you repeat that, please?
First, click on share screen button.
First, I click on the button about
Share screen.
sharing the screen. Okay.
Okay. Then now you see your.
And I see Dropbox, Microsoft OneDrive, Google Drive Box, and I don't have my desktop.
So you click on your desktop.
I don't have this option in my window when I click share screen. I have only the option Dropbox, Microsoft OneDrive, Google Drive Box. I don't have my desktop in the option.
Just get the presentation and play from our end.
Dr. Domenico, you can please mail it to Paris Cancer Conclave ID and we will play it so you can see it and keep speaking.
Okay.
Yeah, we can see your screen.
Yes,
yeah.
sir. Sir.
Just a moment. Can you see my presentation
Yes,
now?
sir. Yes, sir. Yes, sir. Please start a slideshow.
Okay. It's okay?
Yes,
Yes,
yes.
sir.
You can click on slideshow. We can view your screen.
Okay.
Yes, yes, we can see your slide
Sorry,
now.
I am sorry.
Perfect.
I am sorry. Good day from Italy, and many thanks to the organizer and especially to my moderator, Dr. Aditi Agarwal, for inviting me. Thank you so very much, especially for your presentation. To stay at the topic of cervical cancer just treated on TISOL CE, I wish to share with you the status on imaging advance and impact on target volume delineation and oncological outcomes in external beam radiotherapy of cervical cancer. About target volume delineation in external beam radiation therapy, all of you know the reference, the literature, scientific literature reference, where the delineation of pelvic lymph node, we know that is CT-based for clinical target lymphnodal volume. And we know the boundaries to contour, to delineate lymph node, pelvic lymph node, common iliac, external iliac, internal iliac, obturator, and presacral, and the advice to contour with adequate margin each lymph node station, where the delineation while MRI role and particular T2 weighted sequence in the delineation of gross tumor volume and subclinical surrounding structures such as cervix, uterus, parametrium, and vagina is crucial. And we can see the IT2 weighted resolution to identify this structure. So for this type of volume, gross tumor volume, and surrounding areas, MRI is crucially is mandatory, and you can see very high resolution with this type of sequence. So CT MRI fusion, I think, is mandatory in cervical cancer external beam radiation therapy. Probably with this type of flow chart, but is very, very important to integrate MRI scan in the planning for volume delineation, because we can use CT scan for lymph node clinical target volume delineation, MRI scan for gross tumor volume delineation, and subclinical surrounding area is very important, this type of fusion. But it's possible to further improve the definition of clinical target volume called one, gross tumor volume plus subclinical surrounding areas with new imaging methods. This is the main question, I think, which is the contribute of new imaging method to improve gross tumor volume and surrounding subclinical areas delineation. We at my institution, so now we can see the possible role of contribution of diffusion weighted magnetic resonance, and at my institution we at Radiation Oncology Center of Chieti University in Italy, we conducted a retrospective study about this topic, about the volume definition with both sequence, T2 weighted sequence and diffusion weighted MRI, to evaluate if diffusion weighted MRI can improve the accuracy of delineation of gross tumor volume, especially. And the rationale of this study and this topic is that the diffusion weighted MRI, we know that evaluates the random motion of water molecules mostly present in extracellular space, tumor density cellular showing a restricted diffusion, and the parameter is ADC coefficient. In diffusion weighted imaging, cancer has an increased signal intensity, and we have a reduced ADC coefficient. DVI MRI might improve tumor volume definition and is an encouraging functional imaging in the definition of biological target volume, capability for detecting highly metabolic region. Our study is a retrospective study in order to assess different in the definition of gross tumor volume based on T2 weighted versus compared to IDC maps and compared to diffusion weighted imaging. We evaluate also the inter-observer agreement between radiologists and radiation oncologists, both with experience in the gynecologic cancer, with the aim to improve volume delineation in patients with cervical cancer. And you can see on your left GTV, gross tumor volume, defined with T2 weighted sequence, and on your right the gross tumor volume defined with DVI hemorrhoid with ADC maps. And you can see the smaller volume in right panel when we use DVI and ADC map, and this can be a very important factor, because significantly smaller volume were obtained for the CTV when using ADC maps compared with classic T2 weighted MRI sequence alone. This might suggest that adding, because it's important, the multiparametric MRI in the planning, not only T2 weighted sequence or only DVI MRI sequence, but multiparametric. So adding functional imaging such as ADC maps obtained from DVI may give more information for tumor delineation, with a good agreement in gross tumor volume delineation between radiologists and radiation oncologists. So with also a good reproducibility in the lecture of MRI image in T2 sequence, and also for DVI. Another very interesting data prospectively is given by the introduction of the PET-CT in the delineation planning. Contrary to DVI MRI, we don't have much data, and it's very important to define the methodological approach in introducing PET-CT in the planning. This is a very important question. We have much more data about multiparametric MRI in the planning, adding IDC in DVI imaging to classical T2 weighted MRI sequence. For introducing PET-CT in the planning, we have few data than MRI, and particularly is lacking the method in using PET-CT, because it's important the choice of segmentation method because the choice of segmentation method may affect the assessment metabolic tumor in PET-CT with 18 FDG. We use, for example, SUV-max or SUV-main values. It's important to define the method. We can use SUV-max 2.5, threshold of SUV 35%, threshold of SUV 45%. It's very important in the method the comparison with tumor volume in MRI, because MRI is the gold standard in the today the contouring of target volume delineation in pelvic tumor and in cervical cancer too. And the aim is also in this case to search to have smallest volume and in studies, in preliminary studies, a threshold of SUV 35% seem to be the most reliable method to delineate target volume in terms of gross tumor volume. So very probably we should expect, once the method has been developed, because it's very important, the method, to move toward hybrid imaging, PET-CT and PET-MRI, in general in pelvis external beam radiation therapy, and so also in cervical cancer. Probably in the next we have a planning with fusion CT, PET-CT and MRI to combine their characteristics to define more accurately gross tumor volume, and probably this is the future. So in the summary, what message we take home for imaging in target delineation? We can talk about cervical cancer, but I think this talking we can have for each pelvis tumor, because we know that the importance of MRI imaging in the resolution in the pelvic anatomic district. We know that T2 weighted MRI is the gold standard for gross tumor volume and surrounding areas in the pelvis. T2 weighted MRI plus diffusion imaging in MRI, so multiparametric resonance is a very useful optimization in the gross tumor volume and surrounding clinical areas. 18-FDG PET-CT in addition to MRI and CT planning. Now we have a few data. Maybe the adding of 18-FDG PET-CT can be the futures. About the imaging advance for oncological outcomes in cervical cancer, but we also for this topic can add each pelvic tumors. We know that MRI is also in this case, for this objective is the gold standard. You can see a classical situation at baseline and post radiochemotherapy in cervical cancer, and you can see in the sequence at the top of the situation at baseline, and in the sequence below the situation post radiochemotherapy, with evidence of a complete response. But mostly we can appreciate the high resolution also in this case of a combined sequence of T2-weighted MRI and diffusion imaging is very important. It's the gold standard, the multi-parametric MRI, also in response evaluation. But what more? What next in this field? The attention of scientific research has focused mostly on the predictive role of modern functional imaging in order to prospectively evaluate the possibility of modulating personalizing treatment in each type of pelvic tumor and in cervical cancer too. And the results are very encouraging both in the pre-treatment prediction. You can see is a very important study about pre-treatment prediction, and these authors conclude affirming that predictive person achieved in this small exploratory dataset suggest that parameters from baseline MRI and FDG per CT may contribute to prediction of a early response to radiochemotherapy in cervical cancer, but we can talk about rectal cancer, is same situation. And also in the definition of time window, we talk about at baseline prediction for early response, but which is the time window to evaluate a possible early detection of response to concurrent chemoradiation in cervical cancer, but I repeat, we can extend this talk to other type of pelvic district. These authors define, and the literature confirm, the position of early detection during the treatment at 14 days after radiochemotherapy start, and about in the second week, at the end of the second week of the radiation chemotherapy. And you can see multi-parametric resonance with the T2-weighted sequence and DVI, and you can see the sequence in different time with the result at 14 days in this study. Same for early prediction, response prediction, when we use FDG PET CT in predicting response in locally advanced cervical carcinoma, but also in other type of pelvic tumors. And we can see the value of at baseline yearly at 2 weeks, at the end of 2 weeks from the start of radiation chemotherapy, and post radiation chemotherapy. So it is in this case, we can see the potential role of PET-CT in predicting in early predicting of the response. So in summary, also for this topic, and to conclude my contribution, for the oncological outcomes in cervical cancer, we can affirm that MRI multiparametric MRI is the gold standard, and the time is between 6-8 weeks after radiochemotherapy ending, and this is important both for definitive radiochemotherapy in cervical cancer, neoadjuvant radiochemotherapy in cervical cancer, neoadjuvant radiochemotherapy in rectal cancer is the gold standard multiparametric MRI. What more? What next? Focus is on response prediction at radiochemotherapy at baseline time in early timing, 14 days, 2 weeks after radiochemotherapy start, and with which modality, imaging modality, MRI multiparametric, always with T2 weighted and DVI, and or introducing 18 FDG PET CT. The future probably is toward a personalized treatment in terms of intensification or de-intensification treatment. I thank you for your very much for your attention, and I sorry again for a problem at start of this presentation.
That's absolutely fine, Dr. Domenico. Thank you for the wonderful talk. And we have a number of questions. So starting with the first question is that what would be the sequence of MRI that you would usually use for your planning MRI along with CT? Would it be only T2 or any other sequence as well?
No, especially T2 sequence. MRI T2 sequence is they are the most important and most give the most resolution image T2 sequence. Absolutely.
Right. So only T2 would suffice.
Please.
I'm saying only T2 sequence would suffice for a planning MRI.
No, we consider all the sequence in the MRI, but the most important to evaluate the resolution of gross tumor volume are T2 weighted sequence. It's important whole MRI evaluation, but when I need to have very high resolution of my anatomic district in the pelvic, we use specially T2 weighted sequence and adding DVI MRI because the resolution is very, very high, more high.
Right. And the second question is that when we have a contradictory clinic.
Sorry, I lose your.
Dr. Aditi, you're not audible.
Sorry, I lose the question.
I think there is a network communication problem.
She'll be joining shortly, I think.
Okay. So the.
Yeah, she has joined.
Yeah, Aditi, now we can see you and hear you. Please repeat your question.
Yeah, so I think there was a problem with my network. I got disconnected. Dr. Domenico, my question was, the second question was that when we have a contradictory clinical and radiological finding in terms of parametrial involvement, what would you consider to be more reliable?
What type? Which type of image sequence? to define parameter target.
So if we have MRI and we have the clinical examination findings, would you rely more? For example, the clinician assesses that the parametrum is involved. However, the MRI suggests that parametrum is not involved. So would you rely on the clinical finding or the radiological?
Both are very important. I think the gynecologist visit in narcosis is very important, but we need the confirm with MRI imaging. I think both, but MRI imaging has very high accuracy in terms of specific and sensitivity.
Okay, so you would go with the MRI better than the clinical findings because it can be subjective.
Sure.
Right. Okay, and how confidently can you omit cystoscopy and proctoscopy with suspicious involvement of bladder and rectum on MRI? So would you go ahead with cysto and proctoscopy, or you can omit them in a few
No,
cases?
we usually we don't use this type of method, endoscopy, cystoscopy on rectoscopy, because it's very important the visit, objective visit, but I think the imaging is very very central to evaluate any problem inside the bladder and inside the rectum. Except in the rectal cancer and in the bladder cancer, we don't use in the staging and in preliminary has preliminary examination in the planning endoscopy. Absolutely no.
Okay. Okay.
Except in the situation of I can have a fistula, for example. If I suspect or if I see a fistula, is very important to complete with this type of examination before to start a radiation therapy treatment. We know that a fistula is a contraindication, absolute contraindication for radiotherapy treatment.
Right. So the next question is that PET that you use, the PET imaging that you use for planning. So would you rely for the planning of the primary tumor or for the nodal planning? And wouldn't the edges and the borders cause an overestimation of your volumes, and how really would they help?
Thank you very much for this question, because is very important. PET-CT respect to hemorrhoid is very important both for GTV and for node, for lymph node delineation. The hemorrhage, multiparametric hemorrhage, we have seen that is important and mandatory for GTV and subclinical area around PET-CT for both gross tumor volume and lymph node. The problem is to insert PET-CT in the planning. We need to have a specific methodology. We need to find the appropriate protocol to insert the PET-CT in the planning. We have seen the problem about using of SUV. Other problem is the position of patient to plan a PET-CT in the same setup of CT simulation with bladder feeling, with rectum feeling. So we need to clarify this question before to insert PET-CT in the treatment planning. But the PET-CT has very high potential both for the GTV and lymph node.
Okay.
Now we don't use PET-CT in the planning. We have PET-CT in the staging, early response. We have a study ongoing, an ongoing study with the PET-CT to evaluate the PET-CT and MRI, functional MRI at baseline in early prediction for early prediction response during the treatment, and at the end at 7-8 weeks after. But we don't use PET-CT in this moment in the planning for before to clarify this question.
Right. So most of the times, the kind of tumors that we see in the OPD are really bulky tumors. So when we delineate with the help of the advanced imaging techniques like MRI and PET-CT, do you think it would really add anything to it? Because it would add anything to the oncological outcomes, because the volumes become really large. And doing IMRT in such bulky tumors can actually be problematic, because image guidance and the movement of the uterus during treatment is an issue. So does it really add to the oncological outcomes?
Completely agree, and it's very important. I don't know if in IGRT we can put the I think is ongoing research, because I don't think that at this moment we can use IGRT during the treatment as the standard, absolutely, because we need to study many topics about and for adaptive radiotherapy. We need to clarify, and we need to study many questions about the position of this imaging during the treatment, and to shrinkage, to reduce and to modify our planning in course of radiochemotherapy. I think we need a caution for this topic.
Right. So, would you extend your CTV margins for the nodes beyond 7 mm in any particular cases?
Yes, the recommendation. Sorry, you talk about the margin to give to the vessel to contour accurately lymph node. Just
right.
Correct? Okay.
Right.
Absolutely. We need to 7 millimeter when we follow vessel distribution in anatomy radiological image in CT. We need to be at 7 millimeters around vessel to have the to be safe to contour accurately adjacent lymph node station. Absolutely, is a recommendation from guideline is very important. We we have very we give very high attention to this point, especially during resident school, young resident school, to have find vessel and so the adjacent lymph node station. Absolutely, it's very important. 7 millimeter around the vessel. Right. We need to know the vessel in a CT image.
Right, and you just mentioned about neoadjuvant chemoradiation for cervix. So how often do you practice neoadjuvant chemoradiation, and when would you prefer that to radical chemoradiation?
In cervical cancer?
Yeah.
I think that we must affirm that definitive radiochemotherapy is the gold standard. But especially in T2B tumors, many experience from big school of oncology center, such as Catholic University in Rome, Presso Scambia group, they use neoadjuvant chemoradiation in T2B cancer, cervical cancer. At this moment, I have not update about this point, and so the guideline for cervical cancer indicate that the standard approach is definitive radiochemotherapy, but many institutions, I think very soon we can have a change of this standard, and we can go toward a subgroup of patients that for neoadjuvant radiochemotherapy.
Okay.
Also because neoadjuvant, we talk about the imaging in this session and the value of imaging, but when we have the surgery post neoadjuvant radiochemotherapy, we can have also the histopathological specimen, and we can correlate our data, imaging data, with histopathologic specimen. This is very important to know both the value of imaging at baseline, yearly, and post, but also to improve the modulation and the personalization of treatment in terms of intensification or the intensification.
So at present, it would be investigational because the standard of care is radical chemoradiation.
Yes, absolutely.
Okay, and would you recommend SBRT in any form or for any kind of cases who have recurred in the cervix, primary or the node? For node, I understand, yes, many people do advocate. But for primary cervical recurrence, would you advocate SBRT?
Both primary and if I understand well, you ask me the indication of the weight of primary tumor and the lymph node lymph node in the radiochemotherapy prescription, or I understand not well?
So I'm trying to ask that for a case of cancer cervix treated radically with chemoradiation, if the patient recurs in cervix or in the nodes, would you use stereotactic radiation?
No, absolutely. No, in the pelvic, we use stereotactic radiotherapy also in oligometastatic disease and in pelvic cancer, also in prostate cancer, in low risk cancer and intermediate risk cancer, favorable intermediate risk cancer has ultra hypofractionation schedule, but no, we don't use, and I think I don't have update and about the using of stereotactic radiotherapy in other site of pelvic cancer, except only prostate cancer, where we have very important data and two randomized study for using of stereotactic body radiation therapy, also for low risk and favorable intermediate risk in prostate cancer, not for other type of pelvic cancer, except in the oligometastatic setting disease, but is other argument.
Right. And just one last question, as we've already overshooted on time. Would you advocate re-irradiation for such a patient by conventional fractionation? And what would be your dose fractionation and your OAR constraints for bladder and rectum in that case?
Except in prostate cancer, we use standard fractionation for cervical cancer and rectal cancer. In sometime we use 545 in preoperative radiation therapy in rectal cancer. So we use usually standard constraint value for organ risk. It's very important for organ risk the use of MRI in imaging in the pelvic because we have much more organ risk, new emerging organ risk in the pelvis that we need to contour. I think to pelvic floor, urogenital diaphragm is very, very important, and we need about high resolution MRI to contour exactly these structures. So also GTV is very important, the use of MRI also for organ risk and for applying those constraints to organ risk. But we use hypofractionation only in a particular setting of preoperative radiotherapy in rectal cancer and for prostate. So we adjust the constraints, but we know the constraints, how change those constraints in with this type of schedule.
Right. So as we come towards the end of the session, Dr. Domenico, I understand that with the kind of expertise you have, there can be no end to questions and no end to the discussion. We can go on and on, but in the interest of time, we would have to end here. And I would like to really thank you for accepting this invite, enlightening us on the topic and taking up all the questions so humbly. And now I would like to request Dr. Rajeshwar, who is the Director Medical Oncology at Paras Hospital, Panchkula, to facilitate Dr. Domenico.
Thank you very much. Thank you very much, and good meeting. And I hope we can see live next time. Thank you very, very much.
Absolutely.
Thank you, Dr. Domenico. It was a wonderful hearing you. I mean, your pearls of wisdom. I'm sure all the young radiation oncologists who are hearing you, they have, it has been a great, it would have been a great help to them in understanding how you treat your patient. And it has been a privilege to hear. Thank you very much. And I also thank Dr. Aditi for moderating this session so nicely, and the nuances of the daily radiation, what were there, what were difficulties, and she brought out in great detail some answers from Dr. Domenico. Thank you very much, both of you. And now I hand over to the organizer for the next session.
Thank you very much for the invitation and for hospitality. Thank you very much.
You.
Thank you so much, sir. Thank you, Dr. Aditi. And with this, we come to the end of all the sessions in Hall C. And I would like to thank you all the delegates as well as the faculties for active participation. Tomorrow we'll be starting sharply at 9:30 a.m. So do join tomorrow. And from now, it's a goodbye from all of us.
Thank you.
Thank
Wonderful
you so
conference. Wonderful. Thank you very
Thank
much.
you.
Thank you, everyone. So if the quiz is going on in Hall D, the delegates can join there for the quiz.
Oh.
Thank you, Dr. Domenico.
Thank you.
Thank you so much.
Thank you.